Hello audience, my name is Kyung-Yeol Ho and I am general surgeon working at a university hospital in Seoul, Korea. The contents of this video clip is the mechanism of diabetic surgery. If you don't have any information about the metabolic surgery, it would be very difficult to understand, even useless. It may be the waste of time. But if you are a surgeon or the endocrinologist, please give me a feedback. In our country, normal body weight type 2 diabetes is predominant than obese subject, although getting increased in these days. That was the reason why I concentrated normal body weight type 2 DM, and already I have successful outcomes. It has been 3 years since this type of surgery went. I think I found the most reasonable surgical technique for normal body weight type 2 diabetes. And this kind of concept is maybe the first trial in the world. The outcomes are extraordinarily excellent and guarantee high postoperative gastrointestinal quality of life. My intention of presentation is not only perform proper treatment, but also provide right direction of research or investigation of metabolic syndrome. We have been conducting metabolic surgery for normal body weight type 2 diabetes since 2009. BMI less than 30 was indicated. From year 2009 and until 2015, 183 patients underwent operation. Anti-diabetic outcomes were more than expected. In spite of a long history of diabetes, more than 80% of patients were controlled. Anti-diabetic effect was durable. Glycemic control was sustained. Importantly, there had been no surgical mortality without major surgical complication. Underlying mechanism behind the excellent outcomes were regarded as a complete foregut exclusion, followed notable change of postprandial serum incretin. A month after surgery, postprandial GIP was decreased to half level, 53% compared to before surgery. And the GIP-1 was increased almost threefold compared to before surgery. Outcomes are comparable to biliopancreatic diversion, which was most potent anti-diabetic surgery in history. The procedure was tolerable, and there had been no surgical mortality and no severe complication. But mild symptoms such as bile reflux, dumping syndrome, marginal ulcer, caused by the absence of pyloric sphincter function was an obstacle. Incidence of gastric cancer in the bypassed stomach is negligible, but high prevalence of gastric cancer in the previous generation still makes people worried about possible stomach cancer in the bypassed area. And moreover, these shortcomings are usually permanent. Further clinical application of the procedure was getting difficult. To overcome obstacles and the satisfactory life quality after surgery, the procedure was modified under the regulation of 3 principles. First, preservation of entire stomach to allow endoscopic surveillance. And second, the pyloric sphincter preservation to ameliorate post-operative GI symptoms, which is related to the absence of sphincter function. And finally, securing more than 200 cm of biliopancreatic limb to achieve effective antidiabetic outcome, and any duodenal epithelium between stomach and jejunum should be excised to avoid recurrent hypoglycemia. To understand these principles, following evidence support causal relationship between remnant duodenum and recurrent hypoglycemia. One of the prejudices associated with metabolic surgery is, according to the outcome of DJB to type 2 diabetes. As far as we are concerned, the outcome of DJB is inconsistent, but meticulous and comparative investigation of paper show that outcome is clearly discriminated with two groups. One is favorable or acceptable or promising. The other group is unacceptable and unfavorable or disappointing. Surgical technique has a subtle difference according to the description of surgical method in each paper. That is Pylorus excluding DJB and Pylorus preserving DJB and endoscopic DJB liner. The interesting thing is determinant of a favorable outcome is the existence of recurrence or not. And mostly recurrent is determined with the surgical technique. This is an algorithm of the flowchart for the enigma. Inconsistent outcomes are not true. There is a consistent outcomes with surgical technique. First clue is clearly discriminated with favorable or not. Second, two surgical technique has favorable outcome and one surgical technique is unfavorable. And two different possible clues can be compared. Is duodenal mucosa is exposed to nutrient and proximal and distal bowel are connected or not. With this combination, the preliminary answer is just like this. Anastomosis of duodenum and jejunum is related to the recurrence attributed unfavorable outcomes. So, is there any bridge between duodenal jejunal anastomosis and recurrent hypoglycemia? Understanding unique physiology event and adaptable reaction of intestine are essential. Simultaneous compensatory intestinal epithelial regeneration can make recurrent hypoglycemia through the gradual dispersion of the duodenal epithelial cells to alimentary limb of jejunum. Consequentially, different two epithelial lineage is scrambled together and proliferation. Unique pattern of intestinal epithelial regeneration. Stem cells are located at the bottom of the crypt and then migrate upward. Then exfoliated to the bowel lumen from the top of the villi. During migration, crosstalking between epithelium and the mesenchymal cell determinate specific lineage. So, crypt and mesenchyme is very important to cellular differentiation. Post-bypass compensatory adaptive change of connected jejunum after bypass surgery provides us another important clue. The picture is 10 months after jejunal ileal bypass. As you can see in the picture, functioning in continuity bowel is markedly hypertrophied to compensate insufficient absorption. On the contrary, bypassed jejunum in the right side show atrophic change. This animation is to understand the scrambled proliferation of two different epithelial lineage at the alimentary limb. Proliferation of scrambled epithelial lineage at the distal jejunum is attributed by anastomosis of two different epithelium. This slide is same animation with prior one. The dispersion of duodenal epithelium with a concomitant compensatory hypertrophy attributed proliferation of two different epithelial lineage in the alimentary rim is assumed mechanism of recurrent hypoglycemia. This is summarized the supporting evidences. Surgical Pylorus excluded DJB never show recurrence pattern. And second, even though similar area of duodenal first portion is exposed to the nutrients after endoscopic DJB liner installation, recurrent pattern of hypoglycemia exclusively found in surgical pylorus preserving DJB. Immediate after surgery or intervention of DJB, anti-diabetic effects are similar in every procedure until not-early recurrent hypoglycemia takes several months after surgery. Okay, this is the edited procedure with double speed. The infraduodenal tunneling for transection and the transection of duodenal first portion just distal to the pyloric sphincter with the linear stapler. And preparing the small intestine 200 cm distal to thoracic ligament is prepared, and tag exchange is made between the small bowel and the stomach, and the small incision in the epigastric 5 cm. The two bowel are exteriorized, and first open the proximal portion of the distal end of stomach, and duodenal tissue is removed or cauterized. And the interrupted suture is very important to preserve the sphincter function. And that is all. Okay, this is summary of surgical outcomes. From December 2015, 65 patients underwent surgical treatment. Among them, short-term follow-up was possible in 35 patients, and the BMI change was negligible. 25.4 to 24.3, but HbA1c was decreased from 8.7% to 6.4%. More effective in relatively low BMI subject. This implicated metabolic surgery in a true sense. Insulin was not necessary from just after surgery in 10 to 12 patients. None of the patients show recurrent hypoglycemia, and post-operative gastrointestinal quality of life was more than better. Okay, this is a final slide. The take-home message. Post-operative quality of life is as important as effectiveness of surgery. Understanding post-operative intestinal epithelial proliferation following alteration of gut hormone is an important determinant to outcomes. Pylorus preserving single anastomosis DJB with complete duodenal exclusion is function preserving, effective, and safe procedure. Thank you very much.